Good evening, everyone. My name is Councilwoman Brigida Fields. This is the Health, Aging, and Disability Committee meeting for March the 22nd, 2023. I am the chair. I represent the 5th District. And at this time, I will call the roll for those members of the committee first. Maria Cabrera. Councilwoman Maria Cabrera. Councilwoman Yolanda McCoy.
Here.
Councilman Albert Mills.
Present.
Councilwoman Xanthia Oliver. Councilman Vincent White.
Present.
Council President Trippy Congo.
Here.
Thank you. As a friendly reminder, only members of the committee should be making motions and seconding. We don't have any legislation to vote on this evening. We have 2 presentations. Our first presentation will be given by Melissa Smith, and her presentation is from the Delaware Department of Health and Social Service, Division of Services for Aging and Adults and Physical Disabilities. Miss Melissa, are you ready? Miss Smith, I'm sorry, are you ready?
I am ready. Thank you so much.
Thank you.
All right. Is it okay if I share my screen to show some slides?
Yes.
All right. Great. Looks like it's disabled. Let me try one more time. Yeah, I don't.
Oh, I'm sorry. They will share the slides for you.
That
You
works.
just tell them
Thank
when
you.
to go to next.
Okay. I will. Thank you. Well, first of all, thank you so much for the invitation. I'm really grateful to be able to talk about our division, and certainly looking forward to making connections with you all as we look to improve services for Delawareans and make sure that we are meeting all different needs of older Delawareans and persons with disabilities in Delaware. So as an introduction, I'm Melissa Smith. I'm the director of the Division of Services for Aging and Adults with Physical Disabilities. And our vision and mission is to promote dignity, respect, and inclusion for older adults and people with disabilities. Our division, DSAPID, it's called in short, so if I refer to that language, that's still us, is one of the largest of the 11 divisions within the Department of Health and Social Services, with the mission, as we said, to promote dignity, respect, and inclusion. And we strive to preserve health, dignity, and promote self-sufficiency for older adults and individuals with physical disabilities. We look to do so by providing access to and coordination of the right services at the right time and in the right place. And I am ready to move to the next slide, please. So I'll walk you through our core services and supports. Our division currently serves about 15,000 people with home and community-based services in the community. These include the division's core services of nutrition, home health, adult day services, caregiver supports, and legal assistance. Our division provides services and supports including information and assistance through our Aging and Disability Resource Center, case management and options counseling for linkages to other supports in the community. We provide community nursing, adult protective services, home and community-based services, and residential care at our Delaware Hospital for the Chronically Ill. And that facility currently has a census of 84 residents. And I'll move to the next slide, please. Here is a list of many of our most prominent services and programs that we support through our division. I wanted to orient you to not only the list of all of the services that we provide, but a nuance that we're working to adjust going forward. And that is we also duplicate services with the Division of Medicaid and Medical Supports. So those services that are listed in the blue box, starting with adult day, assisted devices, et cetera, those are services that are offered both through Medicaid and through our division. And one of the primary things we're looking to do are reduce that duplication and make sure that those individuals that are eligible for Medicaid are able to get that service package from Medicaid, and allow us to continue to support upstream services that will keep older adults and individuals with disabilities healthier in their homes, and look to provide preventative services upstream social determinants of health, such as legal services, healthy homes, Stand By Me 50 plus, et cetera. And so I'll go into that a little bit more as I talk through our division initiatives. And I will go to the next slide for that, please. So here's a graphic that's intended to show both our goal areas on the screen. It's on the left-hand side, and then our guiding principles, which we look to infuse across all of our efforts. So I'll walk through the goal areas first and then talk about our guiding principles. Our community operations redesign is really an intent to continue modernizing our approach to community supports. As I highlighted in the slide before this one, we duplicate a number of services with Medicaid, and we are looking to complement those medical services that are often needed as you age or have disabilities with more preventative services to foster healthy aging. And so our community operations redesign is really aimed at creating streamlined approaches to help individuals that might be eligible for other support services, other funding streams to support their needs, and help them get there so that we're able to leverage all of our finite dollars towards supporting as many older Delawareans as possible. Supporting aging in place is a very important aspect of what we're looking to do. It's a charge from the Older Americans Act, which creates us as the state unit on aging. It's also been an important goal of the state. I was a participant in the Aging in Place work group and found that there's a lot of common desires of individuals to age in place in Delaware, and yet we need to continue to build those supports. And again, we believe that this is where we can focus on preventative services that focus on healthy aging. And we're actively looking for pilot programs and seeking feedback and building new partnerships to understand the unmet needs of Delawareans, which is why I was really excited to be invited to your meeting and to talk about our goals and hopefully leverage some common goals that we have together. I know that one of the goals on the city strategic plan is for a healthy Wilmington, and I'm interested in ways we can work together to support these goals. An opportunity I wanted to take here to highlight a pilot that we believe is in this vein is a partnership we have with the Habitat for Humanity in the Route 9 corridor. Our division provides Habitat for Humanity funding for their Healthy Homes program, and Healthy Homes addresses home health hazards in order to keep homes dry, clean, ventilated, pest-free. And the program helps low-income homeowners impacted by age, disability, and family circumstances reclaim their homes with pride and dignity. We started this pilot last summer, and to date we have 12 completed tasks with 13 pending. And so I would suggest this is a successful pilot, and we'll look to offer more services, especially if we're granted more funding. We put in funding this year for the JFC requests, and look to expand those services to more individuals in Newcastle County and then statewide if possible. As for excellence in long-term care, I mentioned that we run the only state-run nursing facility, the Delaware Hospital for the Chronically Ill. The DHCI, as it's called, has maintained a 5-star rating since 2020. We're really proud of the interventions we've introduced in the nursing facility to improve person-centered practices, restorative care, and neurobehavioral health supports to our residents with dementia. Through federal funding, a new building is underway to help ensure that residents feel safe and comfortable in a home-like environment. And we say we're excited to finally have a 5-star building to match our 5-star service. Lastly, efficient and effective programming for older Delawareans and those with physical disabilities, the bottom on the left-hand side, is really an underlying effort that we have to continue to leverage every dollar that we have. We're funded both through a capped amount through the Older Americans Act and then through general funds allocated through the state General Assembly. And so we want to make sure every one of those dollars is used as efficiently and effectively as possible to get to the goals of older Delawareans. Now, for our guiding principles, everything that we do, we want to do in a person-centered way, honoring the individual at the center and their goals and their desires. and move intentionally away from a medical model where we prescribe services. Instead, we see ourselves as partners to the goals of individuals in the community. We want to support our workforce, both our stateside and then our partners that we see in our contracted services. We know that workforce is an incredibly challenging issue right now, and it's one that we look to support both through training, development, recruitment, and partnering with other efforts to look at education and other pipelines that can look to assure that we have the workforce we need to support this population. Diversity, equity, and inclusion is something that's really important to us to infuse across all initiatives. And we are actively working with some technical assistance through the National Center for Advancing Person-Centered Practices and Systems to help us do some asset mapping and engagement work to better reach underserved communities and communities that we don't have as strong a linkage to as well. And then lastly, we're looking to be a self-correcting agency. We're in the process of hiring a chief of continuous improvement and look to be an agency that continues to set the bar high, measure our goals, and assure that we are meeting not only our goals, but the needs of older Delawareans. So I think that is it for my formal comments, but I am more than happy to answer questions or go over anything in detail. Here is a list of a variety of different ways to contact us. The first three will guide you to our Aging and Disability Resource Center, where you can get someone on the phone right away, or we've revamped our website, and I think you'll find it very intuitive and user-friendly. Additionally, our APS report line has been revamped to hopefully a more memorable number, APS 4302, the area code for Delaware. And then, of course, you're always more than welcome to reach right out to me directly as the director. So with that, I'm happy to entertain any questions or comments.
Thank you, Ms. Thank you, Ms. Smith. Do we have any questions from any of the council members? Councilman White?
Hello, Ms. Smith. Thanks for that presentation. What has been your experience, may I ask, in reaching out to families where English is a second language? And I would just a quick follow-up, are any of your documents in a language other than English?
They are, Spanish being the most common second language that they're available in. We regularly make our printed materials and outreach materials available in Spanish as well. And then on demand, we have a translation service we can use to alter other documents. I can think recently we helped to translate an advanced directive document into Korean, I believe, to help a physician and their families work through that decision-making process in their own language. We need to do more, and that's why we're receiving technical assistance through NCAP so that we can understand where those gaps are and also better understand where we may need to make some critical hires, particularly around people with different backgrounds or language that speak different languages, so we can have a better direct connect with the people we serve.
Thank you.
Sure.
Councilman Mills?
Yes, good afternoon. Thank you, Ms. Smith. Appreciate the presentation. Sure. Are there any income restrictions in reference to qualify for services?
Technically, no. In that we are, as a state unit on aging, our services are available to all older Delawareans and individuals with disabilities. With that said, because we have a very long wait list, we need to prioritize based on ability to pay, and we'll continue to do so as part of our efforts and goal areas to leverage funding, meaning there are people who could afford to contribute to their own care that right now we aren't leveraging cost sharing as effectively as we could, and so we would look to do that. But in a nutshell, we offer case management, options counseling, caregiver supports. There's a number of services that really don't necessitate income. It's more about capacity and an overall ability to serve, and so those individuals that are lowest income will be our highest priority.
All right, thank you. May I follow up?
Yes.
And what sort of prevention services are available, and where can that list be found?
Sure. The bulleted list is probably a little too abbreviated, and would be happy to get you a guide to services that really outlines everything we can find around Delaware that we think would be helpful to this population. Notably, we partner with both the Division of Public Health and more recently with the Milford Wellness Village to increase the capacity of our health promotion, disease prevention programming. And a lot of what that looks like is education around chronic disease management, so people feel more empowered and informed around managing their own diseases. There are fall prevention classes. As we know, falls can be prevented, but they're also extremely detrimental to this population. We also have been piloting some movement and strengthening classes in a partnership with the YMCA, EPIC, and Christiana Care around physical therapy. And we found really successful outcomes from that pilot and are really excited to expand that as well to further offer supports around mobility, strength, and endurance. This is all the area that we want to improve. And so part of our work around engagement and reaching into other communities is understanding what would be most interesting and appealing and needed in different communities. We don't want to make the assumption that the Y is going to be the place for everybody, but instead we want to make sure that programming is accessible and exciting to those communities that we're in so that people will take advantage of them.
Thank you. May I follow up, please?
Yes, you may.
Yeah. Thank you. I appreciate that. In
Sure.
reference to partnerships, is there any, have you guys been involved with the senior centers? There's a number of senior centers. I know some of the seniors in our senior centers do not have transportation. Some cannot get to the YMCA. Any thought of having those programs in the senior centers here in Wilmington?
Yes, absolutely. In fact, we do have a relationship with the senior centers. Delaware actually has a really robust network of senior centers, and what we're looking to do is better leverage their role as community hubs, as members of communities, to understand what that kind of program would need to look like. And I think you will see in the next few months, we'll be issuing some more formal requests for information from our senior centers so that we can understand what it is they've been looking for to help meet the needs of their community that we could also partner to support. So coming up right away, we'll be looking for information from the senior centers to help us understand how we can support them as members of the community.
Okay, thank you very much. One last question, if I may.
You-
Where is the new building located?
The new Delaware Hospital for the Chronically Ill,
Yes, ma'am.
it will be on the same grounds.
On the same
as
grounds as State Hospital? Okay.
Yes.
Thank you.
Sure.
Anyone else?
Yes.
Councilman White.
Thank you, Madam Chair. Thanks for the reluctancy also. Ms. Smith, can you give us a picture on the demographics of Delaware ages 50 and over % of populations?
I could, but not off the top of my head.
Okay,
And so I would be,
We'll follow via email. Thank you.
sure, absolutely.
Madam Chair.
You're welcome. I just have a quick question for you. Now, I noticed that you said you're servicing the aging and disability. Have you ever thought of having maybe a couple of satellite offices in some of these, what is it called? Like the towers, the
Senior centers.
the senior centers, or the senior high rises, different things like that. Have you thought about having a satellite office in one of those places that will help them with the case management, filling out this paperwork, and so on and so forth?
We have, and I'm really glad you brought that up. I should have thought to flag that as part of the presentation. We have been, over the last, not quite a year, but several months, piloting that exact approach with the Wilmington Housing Authority and offer office hours through our case. We have a very skilled veteran case manager that will come and hold office hours, advertise it really well so that the members of the housing community are aware. And then they're there to answer questions, make referrals, and otherwise give information. And so far, so good. Right now, I think staffing would be an issue to have a widespread presence in a lot of different places, but I think this approach of having office hours so people can know when to come, will come to them, has been really successful, and I would suggest we would be more than excited to try a similar approach in other housing complexes, knowing that you have a really you have an audience there that is certainly within our population, and an opportunity to connect and also hear what's missing and what we should look to add to our services.
And what was a success? I mean, have you done like a survey of how those services, how they help those individuals within those high rises?
We
Yeah.
have data on that, so let me follow up with you and just let you know how many contacts we've made, the kind of referrals, the kind of information they're looking for. I'd be happy to provide a summary and follow up.
That would be great, Councilman.
Sure.
No, I'm good. Thank you.
All right, anything from the public? All right, well, Ms. Smith, anything? Ms. Smith, I really would like to thank you so much for answering the call and coming to the meeting. And I'm hoping that we can continue this conversation. And next time, hopefully, we can get more people in here. So I'm hoping that we could possibly work on or discuss doing a series on the different services that you do offer. You know, maybe 3 or 4 at a time. You can just kind of like go a little bit more in depth about what those, how you provide those services, and how the population can actually receive them and what they need to do.
I would love that. Thank you. That's exactly what we're looking for, and I was excited to be invited and love the opportunity to continue the conversation and the information exchange. And I'm very sorry I couldn't be there today in person, but happy to show up in person the next time.
No worries at all. We thank you for your time. Thank you so
Sure.
much.
Thank you.
Thank you. Have a good night.
You too. Thank you. Okay. Excuse me. Moving right along. We have Mr. Jerry Balmer, who's doing a presentation on science and donation and transplant. Can you come forward? You can have a seat if you want, if you need to.
I'll stand.
Okay.
Yeah, sure. So, good evening, council members. Thank you for the opportunity to present for you today. Again, my name is Jerry Balmer. I'm here with my colleague, Christina Strong, and we're here to talk to you about a problematic organ donation rule. We're representing the organization Science and Donation, and a little bit of background. Around this rule, we've been talking to people all over the country, and we've been successful in passing a resolution in Philadelphia and the city of Newark urging the federal government to reconsider this rule. So just a little bit about Science and Donation. Science and Donation is a transplant and nonprofit devoted to the support and education of all members and stakeholders in the donation and transplant community. And what I want to drive home here is we're not here to defend bad actors in the system. We're here to advocate for the families that are in the organ donation process. So a couple things about Science and Donation. They believe donors and transplant recipients alike deserve a well-aligned science-based system. Their goal is ensuring that metrics and measures used to credential, license, designate, and certify donation and transplant organizations are grounded in science and protected from political whim and private financial influence. And I don't have to tell you, council members, about the challenges of trying to keep money from influencing good policy. And we feel right now with this rule, what it's really looking to do is to privatize the donation system and get access to that list of donors so they can monetize it and make money from it. And we feel that that should be a nonprofit system that doesn't have any political connotations to it. So to help describe how we've gotten to this point, I see it's up there in small font, but I'm gonna go through a timeline that hopefully can demonstrate how we got where we're at. So at the end of 2019, Congress mandated an in-depth peer-reviewed scientific study of organ donation and transplant by the National Academy of Science, Engineering, and Medicine. And moving forward, I'm gonna use the acronym NASEM to describe this report getting done. And for us, this is a big deal because this is what we mean when we say science, data-driven information, which is what this NASEM report reflects. And in November 20th of 2020, with the scientific study still underway, federal regulators at CMS, Center for Medicare and Medicaid Services, approves a rule governing organ procurement organizations despite warnings from healthcare and science professionals on its potential devastating impact. And to describe OPOs briefly, they're the first interaction with a family in the hospital. You can imagine how difficult that is when a family is at the end of life and the relatives are around, and you have to talk to someone about the fact that that member said that he wanted their organs donated, which is a difficult conversation to have at the end of a person's life. And when you look at OPOs, organ procurement organizations, they're one half of the partnership. The other half are the transplant centers, which actually receives the organ and does the transplantation. So at the same time, I should say in February 2022, federal officials proposed giving federal bureaucrats the power to delegate organ procurement responsibilities to uncertified entities, replacing current community-based nonprofit organ procurement organizations. So now this is where, as we were tracking this, it became very problematic to the industry, because here's a report that Congress pays for, that they're looking for responses in order to understand how to reform the system. In February of 2022, during the Trump administration, you have these rules that are being pushed through before the study is done. So during February 2022, at the same time that the studies, that these rules are being pushed through, the landmark NASEM report that I mentioned earlier, study authorized by Congress, is released, highlighting significant flaws in regulations recently enacted by the federal government. And for us, we had the hope that with this report coming out, it would really sound the alarm around the problematic areas of the rule. Instead, almost astonishingly, no one in Congress or HHS has made the landmark NASEM study the basis for reform going forward. And I would tell you, we're spending a lot of time reaching out to federal officials, congressional members, and it just seems that there isn't a will to acknowledge this report and the fact that this report can help inform and really bring reform to the system and inform people on how to move forward better. So when you look at the health equity and organ donation, I want to talk a little bit about NASEM. The NASEM report plainly states Black patients are significantly less likely than white patients to be referred for transplant evaluation and then wait longer for a transplant once listed. Again, it's no secret that there's disparity in the healthcare system. It's critically important that you collect data. I've been part of disparity studies, I'm sure you have, and in order for a disparity study to be effective, you need the data to show people that there's a disparity. NASEM concludes that the absence of HHS requirement to collect disaggregated data by race, ethnicity, gender, sex, age, and language in organ donation and transplant research precludes efforts to fully understand inequities in organ transplantation. So the next slide I'll move to is the contrast of what the Center for Medicare and Medicaid Services is saying. And in contrast, the science in the NASEM report, the rule completely and disturbingly ignores real issues, which is that race-based and socioeconomic disparities in healthcare access and healthcare outcomes do exist and must be reckoned with in order to achieve equity. Now, the next slide, I'll just go into a little bit about problematic areas in the rule for us. And again, looking at it through the lens that you have organ procurement organizations which secure the organ, they have that difficult conversation with the family, and the transplantation center which receives the organ, and they have the right to either reject or accept. So this is why looking at this aspect of the rule is so critically important. OPOs, including yours, face standards and consequences on them alone. It ranks OPOs on the basis of two metrics: the organ procurement rate, which the OPO does control, and the transplantation rate, which they do not control. At the end of the day, if a transplant center decides not to accept an organ for whatever reason that they go through, that isn't seen in the rule, and they're only looking at the metrics of the organ procurement rate. How many organs are the OPOs actually getting to the transplant centers? So OPOs that so-called underperform the medically and logically indefensible standards relative to their peers around the country are decertified and must discontinue operations. This is not done anywhere in our medical system and will cause chaos. So very problematic for us is the fact that they have a plan to decertify, but they don't have a plan for transitioning those patients into some other service while the OPO is decertified. So when the Nason report came out, they have some recommendations going forward. And what they're saying is development of a national performance goals and standardized metrics with which to evaluate the entire system and benefit all patients. So for us, you need to look at the entire system, organ donation, organ procurement organizations, transplantation centers, the doctors. If you want to improve the system, you don't look at just one piece of it. They want a science-based roadmap to improve the performances of all OPOs and transplant centers. Again, we're not picking sides. If there are bad actors, make sure that there are metrics out there that you can identify them and have a plan of how you reform them, not just decertify. The rule to this day ignore the science and sets the stage for chaos in the donation and transplant system. And I just want to read a section of the resolutions we've gotten passed to give you what we're looking for. So what we're asking in the resolution is to respectfully urge the U.S. Secretary of the Department of Health and Human Services and the administrator for the Center for Medicare and Medicaid Services to reconsider implementation of the new rules, revising the outcome measure requirements for and establishing procedures to decertify and create competitive bidding requirements for organ procurement organizations. And that's the end of my presentation. What I would tell you is I've been on this journey for about 3 years. I came to the table with a lot of bias about what organ donation was. I think I had all the conspiracy theories in my head that black people were getting kidnapped for their organs to be sold. If that's happening out there, that's not what I'm caught up in here. It's really about educating our community about the importance of organ donation, the need for health, but unfortunately, if your health isn't there and you do need an organ donation, we need a quality system that is science-based, that is fair, that is equitable, and urging the federal government to rethink this rule and consider their own Nason report. They paid for it, and for whatever reason, they made rules before the report came out, and we're trying to build a grassroots movement, and hopefully Wilmington, Delaware will consider their version of a resolution that would also urge the federal government to do the right thing. Thank you.
Any questions for any council members?
Yes, please. Yes.
Councilman Mills?
Yes, appreciate your presentation, sir. Quick question, 2 quick questions. One in reference to Congress and the HHS. Why are they not acknowledging the Nason study? And 2, why would an agency say no to an organ?
I think what's happened is over many administration, there's been a need for reform, right? So it's not if reform's needed. For us, we're saying what should the reform look like? And I just think you have elected officials that have gone down the road. They're trying to figure out how to work within the current rules. And as a rule that was passed under the Trump administration, I don't feel that there's an immediate will to make that a priority right now, unfortunately, with everything we have going on in the world. And we're just trying to be that squeaky wheel, making sure that we keep it at the forefront of elected officials' minds so that they can see better ways to reform, utilizing the Nason report as one of the tools.
And the turning down of organs?
I don't know if, Christina, you want to talk about that a little bit. There's a lot that goes into the doctors identifying if that organ is a quality organ or not. And I think it just really comes to that you can't control what organs are made available based on however they got procured that organ. And when when a specific patient is in need, for whatever reason, if that organ doesn't match what the doctor is trying to get done, they have the right to, to reject that organ.
Okay.
I don't know if you wanted to add anything.
Sure.
Yeah,
Yes,
Christina Strong is an attorney, my colleague, and she's been how many years in this?
That would give away my age, but
I won't do that.
around 30 some odd years.
Oh, wow, okay.
So I'm with the law firm of Dilworth and Paxson, and I've been very involved in organ donation and transplant issues. The question is, why aren't people getting organs, and why aren't they even being listed for organs? And that is certainly getting into the meat of the inequity. And that's a transplant center question, and it's a system question. Transplant centers are not being rewarded necessarily for taking care of people who are uninsured, for taking people who are very ill, and who don't have access, so that even if they're accepted onto that national list, they may not be able to get to the hospital to get an organ as it becomes available for them. So it's the whole system boiled down. You see the impact really clearly right on the ground there on the transplant center side. But the rule that Jerry's addressing says nothing about the transplant center side. And when it comes to racial equity, really surprisingly, it says this is actually just who gives and how effectively they are reached by organ procurement organizations. We're going to leave the transplant center sides out of this right now, and we're going to discipline the nonprofits in the community who are reaching out to the communities to give. And it's not a race issue, and we're not even going to measure that. And when you don't measure, you don't see. Meanwhile, as Jerry said, the NASEM report wasn't only on donation, it was on equity in transplant. That's what it was about. And so that's totally left out is really surprising on so many levels. And shows to us that the people who were involved in that original rule weren't really talking about who's getting cured here. They weren't talking about access. They weren't talking about equality. They were talking about closing organ procurement organizations. So they created a structure where essentially 1/3 of all organ procurement organizations will be shut down every 4 years starting in 2006. Because it's ranked based on how well they do numerically across the country. So Nebraska is ranked the same way as New Jersey, right? Based on raw numbers, not adjusted for anything, not adjusted for access, not adjusted for anything. So, fortunately, you all here and in New Jersey, we're top ranked. We're not going to get close to 2006. We do a great job getting organs. But year 6, who knows how well we'll be doing, because we'll be compared to the survivors like the Hunger Games. So it was essentially meant to close nonprofits. And we feel that when there's a community question, when you're talking about who gives in a hospital, it should be local, it should be nonprofit, it should be accessible and reflective of where you are, and this rule doesn't do that. So it was based on something other than actual health policy science. I have all kinds of theories, as I'm sure Jerry does. And when we look at who funded the studies that were not peer-reviewed that the rule was based on, you get even more of an idea. But we're just looking to move forward on that point. Did that? Thank you.
Yes, thank you. Yeah.
Councilman,
Yeah, thank you for that, for clarification, because I didn't know what I was hearing in the presentation. I didn't know what the real issue was. I mean, I could surmise, but I think what your colleague says is the key issue in terms of how this affects racial equity in the transplant business. So I'm back to this notion, and just for clarity, do you work for Science and Donation, and are you an employee of that?
I'm a consultant for them.
You're a consultant from them. Are you a lobbyist? Is that a part of what you do?
That's part of my
Okay.
business, yes.
All right. So is there this report that was created, the Hasem report, is that available?
NASEM report. Yeah,
Was
we can get you, would you like a copy of that? Sure,
Yes,
we can get that to you.
that would be extremely important. At the end of the day, and maybe I want to be clear, the report is a part of the issue, but the real issue is how black people, and particularly population is
Absolutely.
affected by this, and who are constantly left at the bottom. So let's take, so that's my focus. Now the question is, if that's my focus, not necessarily my colleagues, what's the best way to address that particular inequity in this resolution that you're crafting or asking us to craft? Does that speak to, is that a part of it in the
What I-
black and white of what we're talking about?
What I would say is, it is absolutely part of our advocacy. And over the 3 years, this is an in-depth issue, so trying to capture it in the slide becomes a challenge because there's so many parts of it. So I would tell you, bringing equity, having black and brown people having access to quality information about what this is and what this isn't, so that they might increase their willingness to be organ donors. Making sure, example that's not in here that I'll add that'll be helpful is that the NASEM report pushed the Association of Organ Procurement Organizations to partner with HBCUs like Howard so they can make sure that doctors are coming into the pipeline so you can eliminate the bias that way. So it's really attacking the system as a whole. So making sure that the transplant centers aren't showing bias in how they put quality people on the list, black people on the list, making sure that the OPOs are putting quality information out there so we can get the number of African Americans that are signing up to be trans donors goes up. And for us, this is part of what it is. We're connecting locally with elected officials to try to educate and partner with organizations on either when there's health fairs going on or health screening that we can push preventative care. But unfortunately, if preventative care doesn't work and you end up needing a donation, that we can give you quality information about what that is.
May I just follow up, Madam Chair?
Yes.
It's a lot of moving parts.
Yeah.
And what works best for me, at least, is to take a bite of the apple on one of those parts. I mean, the bias in medicine is well known, well documented, and the desire to transplant or be a transplant recipient is well documented on the bias on the side of black and brown people for whatever reason there is. But I don't see a continuity of this conversation that gets us, at least gets me, from a direct line, an A to B line. I think that's important, and I'm not saying I speak against any resolution, but you guys stand there with a wealth of knowledge, but sort of bifurcated on how we get to where we got. And I understand it's a lot of moving parts. So that's just my initial
I appreciate that.
overview. And lastly, so when you ask us to help, we don't just want to be a mouthpiece. You know, we don't want to just say this is bad. We want to say, I would hope so, my colleagues and I, we want to say this is how you get to point A, and this is why you get to point A. And whether it's bias in medicine or it's bias in the surgery room or bias in the community, we want to be helpful, but we want to have a little bit more, in my opinion, focused, targeted approach.
I would say we see this as the beginning of developing strong ties in the relationship, because to your point, we have a wealth of information that we want to share. You would know best locally the best delivery method to get that. I would say in my past work, I've seen that joining other organizations on events that are already established, coming into communities to educate, provide information. That's what we're looking to do. So everything you've said is exactly where we're at. We don't want to just do a resolution, get in, get out. We see this as the beginning of growing our coalitions. So, we're connected in Newark, we're connected in Philly, and we want to be connected here in Delaware.
Thank you, Madam Chair. No more questions
You're
at this
welcome.
time.
Anyone else have any more questions? I have a couple of questions. What other federal agencies could govern organ donation rules?
Well, at present, CMS does govern organ donation rules, and that kind of makes sense because they pay for kidney transplants through Medicare. And particularly when we're talking equity, for example, in Delaware, it's about 140 people waiting for a kidney in this state. 77 of them are African American. That's astonishing. And that's, yes, it has to do with underlying healthcare access. It has to do with a whole lot of issues. But that's what drives it back to that. So it's not necessarily inappropriate that CMS govern it, in my opinion, but that the rules that they're using to judge these community organizations be science-based and be quality-based and reflect healthcare access issues. And currently, they are neither science-based nor quality-based. You can do everything right in Newark, New Jersey, and still not transplant every brown-skinned person on the list fairly. You can do everything right because there's so many other factors out there. You've got to weigh it, you got to look for them, you got to know what they are, you got to come up with things to address it, you got to need federal support for that. And right now, the rule's like, nope, sorry, you're dead. We'd like you to be taken over, and possibly by a for-profit. And I don't think that's the solution. That's not what we do for our hospitals when they do a bad job. We say, hey, hospitals, do better. Any other healthcare system in the world, we say, do a corrective action plan, fix yourself, do this work. But this is about closure, so that's the concern. So I'm not sure that it's who the agency is, it's what they are being asked by their communities to focus on. And I think that's part of the resolution is saying, hey, here's a community here, and we think you should be focusing on the people who live here, not on closing the organizations that serve us.
Okay. One more question. How is the current administration reconsidering the organ industry rule that you want to change, that you wanted to be changed?
They are not. They are not considering changing the rule when it comes to the closure of organ procurement organizations. They have, under considerable pressure, asked for more information because they got so much pushback like what you're hearing from us, but they have not done anything to move away from that, as far as I'm aware.
Okay. If there's any,
May I do a follow-up, Madam Chair?
yes.
We acknowledge that there's bad actors that are part of this conversation. And I can understand the desire to be somewhat neutral, but those bad actors have a significant impact on black and brown people getting organs. So I can understand the delicacy of this conversation regarding those bad actors, but I can't understand not including that in this conversation because what you are asking will affect good and bad actors, but there's no conversation to say how we move those bad actors, because conceivably we can get what you want done and we still have these bad actors, but yet, and again, political politics or whatever you want to say, politically correct, but those bad actors have an equal influence upon the delivery of organs. So you're asking us to walk a fine line.
Yes.
Okay.
Yeah, what I would say is, I'm sure you can understand this. This presentation that you see here and where we're at in terms of science and donation in the 3 years we've come, we've probably, and I joke around about this, we've probably come from being young adults full of energy and tough language, where we had a lot of doors closed in our face, very activist driven, to being a little bit more refined, and especially with the Nason report, trying to attack this from a science-based metrics, measure people perspective. So I would say to you that depending on who our partners are, we could revisit that, where you wouldn't be out there alone.
Don't worry about me.
Okay, well, thank you for that, Councilman White. Thank you all for your presentation. I would like to say to my colleagues that say it again, Balmir and I have had several conversations along with Councilman Johnson, and we spoke about this issue, and he has given me, because it's to me it's like, I'm a third grader trying to read a 12th grader book, but he has, he's broken it down for me to where as I can understand. And to know me as a legislator, to know me as a person, I don't move easily, and I don't I don't like people to do anything in my community without that engagement and without teaching our people. So you and I have had that conversation where you're going to come to those health fairs and you're going to put that information out to our community so they can know exactly what's out there, what they may be looking for, because I know there's several people it just in our communities alone that don't even know about organ donors, or can they get it, or they just give up and take a bag, or or just be like, okay, well, let me just it's so many different. I've seen somebody that I've grew up with needed something, couldn't get it, and just wasted away. Do you get what I'm saying? So I know what it is about the getting an organ transplant. My cousin needed one. Frederica Hall, she passed away because she couldn't get one. So this touches me in a whole nother realm. And to your question and to your concern, Councilman White, I think we all have that concern, and we all want to make sure that we're going about it the right way. But my aunt always told me that you stand for something or you'll fall for anything. So for me, let's stand for something, because right now, like you said, in 2026, we could be losing our rating in Delaware and not be able to provide for it. You said 144 and it's 77.
That's kidneys alone right now in Delaware, that's the need. And half of the people, 77, that's roughly half.
Mm-hmm.
Actually, it's more than half.
Right. Okay, because that's what my cousin needed.
Yeah.
She needed a
I'm
kidney.
sorry.
So I thank you. I look forward to continuing this conversation, and you'll definitely be hearing from us. And if you feel the need that you have some more information where you would like to break it down a little bit further, or if you would like to have that additional conversation with my council colleague, you're welcome to, and I'm sure he'll give you his email, and you guys can have that conversation. But for me, you can get it from me.
Well, thank you for the opportunity. Great questions. We look forward to working with you, building the relationship. We don't have all the answers. That's why, that's why you build coalitions and partner with people, because you pick up different tactics and strategies of way to do things and a fresh way to look at it. So we welcome any ideas you have and look forward to educating you more about the issue.
Thank you.
Thank
Thank you very much.
I'm
Thank you.
sorry.
Thank you.
Thank you. Okay, that is the end of our presentations. Is there a motion to adjourn?
Motion to adjourn, Madam Chair.
Second.
Okay. It has probably been moved and second to adjourn. All those in favor say aye.
Aye.
Opposed? Opposed? Motion carried. Everyone, thank you so much for coming to the meeting. These are